So wonderful to be here and so great to speak to so many friends and so many names I recognize. So if you were to ask, what are some of the hot button issues that we are seeing from a policy perspective right now? Well, you have to always answer that question with what's happening in the ecosystem around us. As you look at the next 6 quarters, what are we going to see? We're going to see a lot of small hospitals struggle. You start to see, you're looking at bottom lines that are negative. I mean, even Ascension reported a $1.8 billion loss and a minus 3.1% bottom line. And why are we seeing all of this sea of red ink? Well, it's the great resignation and the great retirement. You're seeing a lot of folk, nursing staff and others leaving the profession. You're seeing traveler expenses. You're seeing supply chain limitations and supply chain expenses. So with all of that being said, you're going to see a lot of machine learning, a lot of robotic process automation, a lot of automation coming in an attempt to make those individuals who are still working more productive, reduce their burden, and hopefully return some of the joy in work. But there's a problem, right? Do we, any of us, really know the best practices for deploying machine learning, whether that's clinical decision support or whether that's financial revenue cycle or some other aspect of supply chain coordination? We really don't, as a country, have the guidelines and guardrails that you'd want to ensure these things are fair and equitable, useful for purpose. As Emma knows, I'm fond of saying something like, well, if Mayo Clinic develops a wonderful algorithm on 5 million Minnesotans, and then we deploy it in, say, Georgia, is that going to work or not? I mean, the demographics are going to be different. If you take urban, deploy to rural, if you go international, how do you validate these things? So there's a lot of work going on, some in academia and industry and some in government. And since policy update, let me start with the academia and industry and then tell you how that bleeds into policy. About a year ago, a number of organizations came together: Mayo Clinic, Hopkins, Duke, MITRE Corporation, Stanford, UC, and others, to ask the question, if we took our individual work, because each of us has private, principal investigators and authors starting to think through ethical machine learning and bias, and we collectively published an implementation guide, all for free, right? That this would be our collective wisdom on best practices. Wouldn't that be a good thing? So over the course of the summer, we've all got together, now about 50 organizations. Google and Microsoft have also joined that. So we have Eric Horvitz, who is the chief scientist of Microsoft and also our chair of PCAST for President Biden. We have Andrew Moore from Google, who oversees all the AI activities there. We also have FDA and ONC. So Meki Tripathi is there, and it was Bakul Patel, but now Annie Saha. And they're in an ex officio kind of, we're listening. We can't obviously represent government in this kind of coalition. If you go look at the website, coalitionforhealthai.org, what you'll see there is that over the summer, we have done 4 white papers on such things as ethical use of algorithms, measurement of outcomes, data bias, model bias. How can we, over the course of time, monitor algorithms and make sure they're revised when there's data shift, these kinds of things. So that's good, right? We're going to have this notion of a set of implementation guidance for the country based on collective best practices. But what are we going to see from a regulatory perspective? And since Jen and Emma read the Federal Register every day, cover to cover, I mean, it's just so bold and exciting. It's like Game of Thrones. Well, there are 2 things that have come out in the last week that you should know about. Both fall under the notice of proposed rulemaking kind of rubric. These are not final rules by any means. So the first one is that CMS proposed non-discrimination in health programs and activities rule. Now, page 176, and this is a long rule, right, has in it the following kinds of language. What is the liability if you imagine a provider organization simply takes an algorithm and turns the care process over to the algorithm. As again, I said, we created this amazing thing at Mayo Clinic. We now deploy it at MedStar. Let's pick something in Washington. And they say, oh, it's from Mayo Clinic. Of course, it must be trusted. It must be accurate. It must be fair. And then let's imagine that the patients at MedStar aren't quite the same and the algorithm isn't quite as useful. Who's liable? And what this rule says in the spirit of non-discrimination is AI shouldn't mean artificial intelligence. What it should mean is augmented intelligence. So you can imagine that if this doctor at MedStar says, oh, well, I ran the Mayo Clinic algorithm and it says I should consider this test or this diagnosis. Well, for this patient, that's not quite right. Maybe I'll do this test or that diagnosis. Then it's fine, right? It's just simply stating that there needs to be human oversight and that this should be augmented, not closed loop decision-making turned over to an algorithm. So anyway, guys, an interesting topic because this is kind of the way things are headed with clinical decision support and the various kinds of categories of AI or ML interventions that we would make that humans need oversight. The second and really interesting proposed rule came from FDA yesterday. And this is an extensive rule, and it asks the question, when should machine learning for clinical decision support be considered software as a medical device? And this is, of course, interesting because software as a medical device implies certain kinds of clearance, approval, 510K, pre-cert, all those kinds of things. So they've created, I'm going to call it a structured framework for you taking what you want to do and going through the structured framework in 4 different categories, and then deciding, does this regulatory software as a medical device activity apply to what you want to do or not? And they've given rich examples. And that's what's so good about this FDA proposed rule that came out yesterday. It's actually like 50 examples of things you might want to do and where they sit in these various categories. And you can understand everything the FDA has done, and initially their draft of this was 2019, and then the proposed rule yesterday, is a risk-based framework. And so let's talk through risk. What if I look at, let me just make up something, UpToDate. And UpToDate has in it, oh, for a diabetic with hypertension, consider the use of beta blockers. Okay, well, that is just sort of educational material. It's not an algorithm that's running based on telemetry or image analysis or that kind of thing. So presenting that as CDS isn't going to require any kind of FDA approval. Now, what if, on the other hand, I have a closed loop system that's doing real-time monitoring of patient glucose telemetry and making adjustments on their insulin pump in real time to decide how much insulin they're going to get? Well, obviously, the risk of a mistake in that algorithm is death, right? And so the risk would imply that requires full software as a medical device, full FDA rigor. And so you'll see, again, these categories. Are we gathering images or telemetry? Are we doing more closed loop, real-time kind of activity? And then the interesting category 4 talks about, is it explainable? And is there a sort of notion that we're simply telling a doctor, well, an algorithm has decided that this is a good thing, and oh, here's why it decided that was a good thing. And oh, okay, it's clearly explainable. The doctor can review it. That may not fall into software as a medical device. The problem, of course, is a whole lot of our machine learning algorithms are based on complex multi-modal data without a clear explanation. And I'm going to give you the world's most ridiculous example. When I was a resident in emergency medicine, we had this notion at County. I was trained in LA. If a patient came in from a trauma with their legs crossed, they would do well. And of course, think about that algorithm for a minute. Does that make any sense? Well, not really. No. But think about this. To cross your legs, you need to have a brain that's intact, nerves that are intact, and muscles that could actually move your legs. Oh, well, actually, now what I see, this is really correlation, not causality, right? So what you should have asked is, did they have an intact neuro exam? And then you could predict their outcome or something like that. So, but point being is that just creating a black box where the input is legs crossed or not, and the output is death or life, that would probably be something you wouldn't want to deploy without some oversight, as opposed to something you could more easily explain, neurological exam and prediction, which then could be an equation that may not require oversight. So anyway, I tell you all that. So it's a good rule. It's structured, and it's going to be revised. I am certain in the comment period, people are going to say, oh, well, that example should really be expanded in this or that way, or you should relax this example. So it's, by no means, and you'll see Politico interviewed me yesterday about it. And my comment is, you had to start somewhere, right? You need a framework, something categorical with some use cases, and then we'll polish it together.
But no major concerns at first glance right now? Okay.
Yeah, I mean, right, when you read the thing, it's like, oh, well, that's pretty reasonable. A risk-based framework with enumerated use case and exemplars, right? How do you argue with that? Well, another interesting thing that's going to happen over the course of the next 6 quarters is much more care at a distance, right? And I don't mean just replacing your ambulatory visits with FaceTime. What I mean is hospitals delivering care in the home. Mayo's done a lot of this over the course of the pandemic, of moving serious and complex high acuity care and remote patient monitoring into a home setting. And we found that about 30% of Mayo patients can actually be cared for entirely in their living rooms. And I mean serious and complex, really sick people. And think about who you might do that for. COPD, congestive heart failure, pneumonia, right? They're going to need oxygen, antibiotics, steroids, these kinds of things. They may need physical therapy. You can all do that in the home. Certain things you wouldn't want to do in the home, like somebody had an unstable arrhythmia, right? I mean, obviously that means 5 minutes from now, they could have a life-threatening situation. Probably don't want that in the home. But with COPD, CHF, pneumonia, if somebody's on a downward trajectory, you have hours to do something about that downward trajectory should they need to be transported to another facility. So collectively, Kaiser Permanente and Mayo have discharged 12,000 patients through the high acuity hospital at home program. And what have we learned? And this will have a policy implication, so don't worry. What we've learned is
these patients all over the country or around Mayo, Minnesota, or?
Yeah, so we deployed Mayo initially. We built a command center in Jacksonville, Florida, which is slated to get 40-mile-an-hour winds later today. We're watching that closely, right? And we initially did the Florida area, and then we did the Wisconsin area because Mayo actually has a number of health system hospitals associated in the Midwest. So we did not Rochester, but Midwestern, and then we did Arizona. Kaiser did their entire Pacific Northwest. But everybody's expanding to more and more geographies now. It's just where we started, because we had some control supply chain and staffing quality and such. What we learned is the quality of care in the home is the same as brick and mortar care, the safety, the outcomes, but net promoter score of 97%. If I said, Jen, you can have your pets, you can have your family, there's no visiting hour limitations. The COVID policy for your visitation in your home is up to the family based on their level of vaccination risk exposure and that kind of thing. I think, wow, that's a pretty nice kind of thing to have. Yeah. How many nosocomial infections have we seen, right? How many people have MRSA in their living room? Like 0, right? How about falls? Well, remember, it's your bed and your bathroom, not some gurney in some place that you don't recognize. So falls also mostly disappeared. So, okay. How about readmission rates? Readmission rates are less than 25% of standard hospital readmission rates. Well, why? Because you're not getting that jarring transition from brick and mortar back to home. You're in your home, right? So we'd only discharge you if you were truly ready to go back to activities of daily living. But reimbursement. So that's an interesting question. How do you reimburse this activity? Well, although the pandemic was a tragedy, it did give us regulatory waivers. It gave us hospital without walls. It gave us relaxations in licensure requirements, site of service requirements. So during the pandemic, we saw parity, equal DRGs for the caring of pneumonia in the home as you would see pneumonia in a bricks and mortar facility. The question, of course, is, will this continue? And what everyone hopes is, wow, it's same quality outcomes, better patient satisfaction, lower cost overall. You'd like it to. So a consortium has come together, and this includes Kaiser and Mayo. And when you look at the number of hospitals involved, it's actually 260 hospitals and 114 healthcare systems that have come together. And there's a bill in the Senate and a bill in the House. Starts small. It just says extend the DRG for 2 years past the public health emergency so that there's parity for reimbursement. But the hope is that as the market matures and people understand the value proposition, high quality, lower cost, this will simply be reimbursed as standard care. And but so let me just reflect on one last thing, because I know we want to do Q&A. So my mom entered home hospice last weekend. And you well, Jen's like 29, so she's not going to know. But as you age, what you discover is you are part of this interesting sandwich generation of caring for those below and caring for those above. And you will become experts in long-term care, hospice care, reimbursement policy, who does what and what are the staffing and supply chain issues. It is, I mean, I've been in the industry for 40 years. I serve as a president at Mayo Clinic, and I have a hard time navigating long-term care options and reimbursement. Here's what I think you're going to discover. Hospice is a designation that provides a level of care that is focused on the needs and wants of the patients. Hospice does not imply that there's a definitive terminal diagnosis. I mean, everybody is going to die eventually. Hospice is a set of care. Hospice is fully reimbursed by Medicare. Yeah. So that means you get visiting skilled nursing, equipment, and medications. I mean, this is how great it is. Last evening at 11 p.m., I had medications delivered to the home, right? And it just, there's such a level of attention and empathy and compassion.
Patience. Yeah.
And yet, here's what's also interesting. It is not 24/7 home health aid or assisted kinds of activities, none of which are reimbursed by anyone. And so it's a quizzical issue. Yes, skilled nursing facility medications and equipment, but then home health is funded out of pocket. Now, you might find that you have a long-term care policy. Read the fine print on your long-term care policy. It basically says, oh, well, if you enter a long-term care facility, the policy will not begin reimbursement for 90 days. You have a complete out-of-pocket coverage for 90 days. And then when they reimburse, they might reimburse $100, $200, $300 a day, but yet 24/7 care and a long-term care situation is going to be more expensive than that. So I just tell you this because it's a policy. We've embraced home hospital, and that's wonderful. We've covered hospice care, and that's great. But we should start to look at some of the gaps in our aging society. So many people are going to need various kinds of care services that are neither covered by Medicare nor so well by long-term care insurance.
John, why do you think that, I mean, I agree with you. I think hospice and palliative care is an incredible framework for really catering to the patient. I mean, why do you think in all the years it's been around, we haven't picked up on that? There's certainly been I know, efforts to try to, relieve patients and refocus around patient-centered care. And how come we haven't used them as a good example?
Well, and you can imagine that when you say the word hospice, people immediately read into that certain things.
Yeah.
And it's
Yeah.
like, oh, well, I wouldn't want to consider that because it's my relative. Remember,
Right.
it's compassionate care that meets the
Right.
needs and wants of the patients, whatever that might be. By the way, you can graduate from hospice, right? Your pain controlled, your anxiety relieved, your healing. Graduate. Good.
Yeah. Yeah. But I mean, we haven't used it as a good model. And is there a payment? Is there a revenue issue there? Is it just, not something that would bring in money for folks? Is that probably the reason? Is it a staffing issue?
To be honest, I just don't think people know how to navigate this stuff. And this is what is so confusing. I mean, Emma's heard me say this. We don't have a healthcare system. What we have is a disconnected set of hospitals and clinics, labs and pharmacies. Most of them don't coordinate your data, and most of them don't provide clear navigation. And so you're
Yeah.
left with having to figure this stuff out on your own. And let me just tell you what I did, which, I know this is going to be a little bit more detail than people want to hear, but as a senior vice president at the Harvard Associated Hospitals, I knew everybody in Boston. So all I simply did was call executive vice presidents at various organizations to get what do I do? How do I do it? Who staffs, who pays, and all the rest. Well, great. But what does a mere human do?
Right. Right. Yeah. I mean, that's really horrendous that I mean, what do we do, the rest of us here? Yeah.
Well, I welcome the thoughts of the Executives for Health Innovation Brain Trust, because I think what we need to start looking at is, are there policy changes, especially in that end of life care period, where we should
Yeah.
fill some gaps reasonably
Yeah.
and affordably, but not make
Yeah.
everything so random as it is now.
Right, right. Let me ask you this. Certainly I think, the whole idea of remote healthcare, and you gave a great example there with the hospital at home, which is really hospice care happening right now. Do you think because of the pandemic and because of the reimbursement changes right now that we're in a window of opportunity where people would be more open to that? I know there's a lot of fear right now about things being pulled back, and certainly there's a lot of concern about the economy right now. What's kind of your thought in terms of which direction we're going?
So there's a remarkable window now. And why, despite all of the negative news you read every day, am I so optimistic?
Yeah.
So think about it. The perfect storm for innovation requires technology that's good enough, policy that's enabling, and a culture that gives us a sense of urgency. What's happened? Well, the technology, remote patient monitoring, internet connections. Yeah, we don't have broadband everywhere, but we have pretty good cellular coverage, and technology is good enough. Policy, well, the pandemic brought us policies that cover a lot of reimbursement, licensure, and site of service issues, so that's pretty good. But culture. Every one of us who had to get medical care during the pandemic said, oh, the only way I can do this is if I do something remote. I've never done that before, but let's try it. Oh, it actually worked. So there's a cultural urgency to put into place these new care models, these non-traditional site of service models. And that's why I think it is a remarkable window.
Now, what's going to be your response to all the folks in Florida around Jacksonville that say, oh, okay, we've got all these patients doing remote care and we have a huge hurricane coming? How are we going to be able to plan for these types of situations? There's a lot of fear about remote care and internet accessibility. And so what would be your response to folks saying, we don't want to take that step?
Yeah, so I said that 30% of our patients will do well in a home care environment. And as you plan that out, you ask questions like, well, what is the internet coverage of that area? If there are multiple cell phone providers, if there is an in-home fiber or cable, oh, okay, well, there's redundancy that may be resistant to a disaster. well, how do we evacuate them if they need to be evacuated? Is there an easy way to get them to a different facility? So we ask all those questions. So we do actually sort of set up the risk mitigation. And if somebody is in a very remote area with poor access to transportation and no redundancy, they're just not a good candidate for that kind of service.
And then what about folks who are going to say, this is great, John, but I'm not at Mayo and I'm not at Harvard. You've got lots of resources at these large companies. How does a small community like me here in North Carolina or West Virginia, is this even possible for other parts of the country or smaller, less resource available?
Certainly. So imagine the following, that the reason I run Mayo Clinic Platform is to say there's a set of software components that are available not just for Mayo Clinic, but software components available to organizations throughout the country and the world, so that you wouldn't have to build these components yourself, right? You're just using these, happen to be cloud hosted. Interesting, Mayo hosted them on Google Cloud, Kaiser hosted them on Azure. I mean, it's fine, right? Just cloud hosted stuff that can be used by any organization. And then the protocols, you could inherit some of the protocols that have been developed by larger organizations or use protocols on your own. I mean, it's completely up to you. But here's the interesting use case for rural facilities. Imagine that you would like to expand the number of patients you see, but it takes capital to build new hospital beds. What if you could see 20% more patients and not require any capital to be expended? Wouldn't that actually help your financial situation? And that's what we've actually seen, is that in a lot of our Mayo rural locations, we've expanded capacity 20% without building anything or hiring more staff.
Wow. We've got a great question from Rick Moore, who wants to know, how are you connecting the remote patient monitoring devices back to the mothership? Are you doing this with FHIR?
It's a great question, because as you know, there's a more infrastructure question and then there's a standards-based question. So the infrastructure is, oddly enough, LTE modems. We're doing all this over the cellular network because we found that is just easier to configure and manage, and it's more ubiquitous. All of the data exchanges, yes, are FHIR R4 standard implementation guidance, with some extensions as is necessary, because there are certain domains that haven't yet got implementation guidance. So in fields of oncology and cardiology, there are if you look up M-code, M-C-O-D-E, or M-card, these are some extensions we've done to the FHIR standard to support some additional data elements.
Yeah. Another great question about what are kind of some of the legal implications for some adverse outcomes that might result from, any type of remote care.
Right, and so as you can guess, Mayo starts small, thinks big, moves fast. So how many patients do we start with? 1. And then we said, what did we learn in terms of risk mitigation? What do we need to ensure the second patient gets, the first patient didn't? And we went from 1 to 10 to 100 to 1,000. And then every patient is studied. What happened? What could you improve? So you can imagine that, like any hospital situation, as long as there's continuous quality improvement, risk mitigation, oversight, measurement of all quality indicators and complications, that you go through patient safety organizations, the legal exposure is not particularly different than you would find in any other healthcare setting.
Yeah. Another great question on some of your earlier points around the discrimination and the bias comments earlier. Is there any accountability right now for payer or policies, specifically around that are using bias? For the example that you gave, if they applied a policy that was built on a population that, didn't relate to them, is there any accountability?
None. Right. And so that's the reason that we need these frameworks. And that's why you see the Coalition for Health AI publishing its implementation guidance, CMS and FDA and ONC all trying to put out proposed rules. So there's at least some kind of accountability.
And one more question we've gotten several times. I've got to ask you this, John. There's, I guess, a congressional deal around the cybersecurity provisions right now with the FDA that would actually strip some of the cybersecurity provisions out with bipartisan support. Just, do you have any thoughts on that?
I have not read the specific language, but how about this? Do you know what IoT stands for? Internet of Targets. Not Internet of Things, Internet of Target, right? When you actually look at the easiest way to compromise a healthcare fortress, go pick the device connected to the network with lousy cybersecurity, right? So I would say it's a time to redouble our device-based cybersecurity and not relax it.
Okay, and I know we're going over time here, John, but I'm going to just keep you on here. We have one more question. Rick Moore just wants to know how your animals are doing on the farm.
Oh, well, all good. So as folks know, we have the largest animal sanctuary in New England, 300 animals, 22 barns, 500 volunteers. And what's really interesting in New England is our temperature goes from -10 degrees Fahrenheit to about 100 degrees Fahrenheit. So dealing with the keeping animals happy and healthy, Scottish Highland bulls that weigh 3,000 pounds do not like 100-degree temperatures. They want to be in Glencoe in the fog and rain. So we have misters and fans. Chickens don't like -10. So we have space, heaters that are built into walls without fire danger, other things like that. So all good. And remember, it's all a tech and engineering problem. I have 143 Internet of Things connected devices managed in Google Cloud with full analytics and integration across every animal, light, lock, temperature, water flow, and all the rest. So you got to do something to deal with a place this large.
We know we have a problem when your animals are treated better than the care a lot of folks are getting in the country. So we're really glad that we have your leadership and your perspective to guide us through here. Yes, if only our health system was run as well as your farm animals are taken care of. John, it's always such a delight and a treat to talk to you. And thank you so much for joining us today. And we are going to have this recording out. I do want everybody to tune in to John's podcast because it is incredible. We pushed it out today, and we'll push it out on our follow-up note as well with a link to today. Again, John, we are some of your biggest fans here. So thank you so much for joining us, and thanks everybody.
Great. Have a lovely day. Thank you.
You too. Take care.